Welcome to everyone around the world to this, our second webinar of the ILAE Nursing Section. My name is Sandra Dewar and I'm pleased to moderate our webinar today. I'm a faculty member and epilepsy program manager for the Department of Neurology at a comprehensive center in the US. I take the opportunity to thank our speakers and to thank the ILAE support staff for making the event possible, and of course to all our attendees today for your time and attention. We are proud of our growing membership of nurses. Some of you had requested certificates of membership. These are in process and you should be receiving them quite soon. Some of the benefits of membership to the ILAE Nurses Section is that you can keep abreast of ILAE activities and learn from nursing colleagues. For today's session, please use the QA function to send questions or comments, which we will address after the three talks today. I'd also like to just draw attention to the correct email address, which is in the PowerPoint here. The address on the speaker slides is not correct. The webinar series is a key to developing the nursing section of the ILAE and to reaching nurses worldwide. The series we are presenting provides a platform to promote the essential work of nurses, to share ideas and to learn from each other. The goal today is to discuss the importance of using correct and clear descriptive labels for the epilepsies and the associated seizure types. As you listen to the speakers, please take special note for the reasons the use of correct language is so very important. We will, of course, focus on the current 2017 classifications. The classifications have undergone revisions over time in order to improve the clarity and accuracy of the language we use and to make it easier to communicate about seizures. The talks you will hear today serve to illustrate the practical application of new labels. I will now introduce our three speakers. Patricia Shafer is a leading epilepsy nurse specialist in the US. She has worked extensively in epilepsy, including at a comprehensive epilepsy center in Boston, Massachusetts, and for many years with several public health organizations. She currently dedicates her time to healthcare consultancy and is the chair of the nursing section of the ILAE. Melissa Bartley is a neuroscience nurse who has worked as a clinical nurse specialist for a comprehensive epilepsy program in Sydney, Australia for the past 13 years. Melissa holds a master's degree from the University of Technology in Sydney. She is a past chair of the Epilepsy Nurse Special Interest Group of Australasia. And lastly, Karen Legg is an experienced epilepsy specialist nurse with over 3 decades of clinical experience. She is currently working in epilepsy research in Halifax, Nova Scotia, Canada. She practiced as a nurse practitioner in epilepsy and general neurology for the past 17 years and prior to her semi-retirement in 2022. She is the chair of the Canadian Epilepsy Nurses Group and a member of the executive board of the ILAE Nursing Section. The three talks will now follow, after which we will have a few minutes for discussion, comments, and questions. And please again put those into the chat. Thank you.
Thank you for inviting me to speak about labels in the epilepsy, moving beyond history and stigma. First, there's a variety of different words and labels that we use. And our question is, what do they all mean? You can see some of the older terminology, grand mal seizure, attack, partial seizure, or the newer terminology, a focal seizure, the epilepsies, or much more vague ones that we as healthcare professionals use, but also do patients and families, that they've had an event or a spell or maybe a bad day that they don't really know what happened or how many seizures that they had, but they know that they had a bad day. So it's really important for us as nurses to really understand the words that people use and actually how they define that, to understand really what's happening with seizures or what kind of seizures a person has. Now, I'd like to draw your attention to these position papers of the ILAE, one on the classification of the epilepsies and one on the classification of the seizure types, because we're going to be talking about some of these today, and it will give us a helpful resource to make sure that we're all using the same language. But first, what are the words and labels for seizures? We know that seizures are an event or a symptom. To be more descriptive, though, when we think about a seizure in the brain, we're talking about abnormal, excessive, or synchronous neuronal activity. Or an easier phrase, abnormal bursts of electrical activity. But the word seizure might also be used in relation to other events. So sometimes cardiac events are called seizures. If you look in a dictionary, you'll find definitions for seizure as to seize, or the state of being seized, or to convulse or take hold of. And you can see how people might have perceived these as negatively, feeling that one's body or one's mind is being seized or taken hold of, and that gives that negative connotation for seizure. The more vague terminology, a sudden attack, a spell, an episode, or the word fit. And the fit in many countries is neutral. It doesn't mean anything else other than it's similar to a spell or an episode. But in some countries, and including North America, it's perceived more negatively, and so we try to avoid the word fit or epileptic fit. What are some of the labels and meaning for epilepsy? Well, from the newer definition of epilepsy, we call epilepsy a disease and associated with unprovoked recurring seizures. But I like this second bullet, which takes this further. It says that there's an enduring predisposition to generate the epileptic seizures, but it goes beyond that to the neurobiologic, cognitive, psychological, and social consequences. And that really stresses that epilepsy really is more than just the seizures. And we also now use the word the epilepsies to acknowledge that there are many different types of epilepsy. It's not just one problem. When you think historically, though, epilepsy meant a falling disease or the falling sickness or the prophet's disease. And before Christ, when they used the term the prophet's disease, it was thought that a person with epilepsy had special powers or was given certain respect. Over the Middle Ages, the stigma and the brutal treatment or persecution of people with epilepsy, was much more prominent. People were thought to be possessed by the demons. Now, some of these, words or meanings still might be present in some areas of the world or some cultures. So it's important us to understand what people's belief systems are when they hear the word epilepsy or seizures. Another terminology question is epilepsy a condition, a disorder, or a disease? People feel more comfortable, or some people feel more comfortable using the term condition because it feels neutral and it feels like the disease isn't all of them, but maybe that epilepsy is just a part of them. The term disorder means something's kind of dis or wrong, so some people feel uncomfortable with that. And they feel uncomfortable with the word disease because it makes them think of something contagious or that could pass on to people. Yet in reality, it has the signs, the symptoms, the course, the prognosis as any other disease like cancer or heart disease. So if you want epilepsy to get the attention it deserves, whether it's in the awareness or the funding or the public health resources, the word disease is the appropriate one to use in my mind. Now, the ILAE practical definition of epilepsy is that as a disease of the brain, it can be defined by any of these three conditions: that you've had at least 2 unprovoked seizures, one unprovoked or reflex seizure when there's a probability of further seizures similar to a general recurrence risk of at least 60%. So one might have just one seizure, but imaging studies showing a lesion suggesting a high risk of recurrence, or an abnormal EEG pattern that's showing a high likelihood of recurrent seizures, so a person would be diagnosed with epilepsy after that one seizure. Or if the person's been diagnosed with an epilepsy syndrome. We also now talk about epilepsy as being a disease that can resolve. So they might have an age-dependent epilepsy syndrome, and now they're past that age. So childhood absence epilepsy, and the person's in their adult years, so they would no longer have epilepsy if they've been seizure-free. Or if a person's been seizure-free for at least 10 years and not needing any seizure medication for the last 5 years. And that's a new concept for us. Now, this graphic shows us the framework for the classification of the epilepsies. So if a person has an event or a seizure, you first want to figure out what type of seizure they have. And we talk about the seizure type by the onset. Where did the seizure begin? In a focal area of the brain or a focal network of cells, to a more generalized network or the whole brain? Or maybe we don't know because it wasn't fully witnessed or happened during sleep or the onset wasn't seen. Starting with that onset and labeling it that way helps send you down a certain path, a diagnostic path, a treatment path, and you know better what to expect. Once that seizure type is defined, you then look at that type of epilepsy. But in doing that, you also want to sort for the etiology or cause of the seizures, and are other comorbidities present, other neurodevelopmental disorders, other health conditions that might occur more often and coexist with this form of epilepsy. And when you put all that information together, you can get that epilepsy syndrome and learn much more about the person's type of epilepsy. But let's go back to the type of seizures. Most of us can get by with the understanding and use of the basic version. Again, is it a focal or generalized onset? If it's a focal onset, are they aware of it? Or is there an impaired awareness? So they're not fully aware, or consciousness or confusion is present during all or part of it. And are there motor symptoms or not? So without motor symptoms, it might be that dazed, blank, facial expressing, the behavioral arrest. If you look at a generalized onset seizure, you're also looking at motor seizures with a variety of different motor manifestations, or the non-motor, which are the absence seizures. You could take this to the expanded version, which if you're working at an epilepsy center or in epilepsy research, you're clearly going to want to use. And again, the awareness piece is the same for focal seizures, but you can see all the different, manifestations of the motor onset seizures versus the non-motor, and you may have a combination of the two. Of the generalized onset seizures, you can see many of these are the same terminology that we had in the older classification of generalized seizures, with a little more detail on the myoclonic seizures. And keeping in mind that awareness is presumed to be affected in all of the generalized seizures. And you can see under the absence seizures that we have more descriptives of the different types of absence seizures. It's also important to realize that there are some of these vaguer terminologies we no longer use because they are vague. They don't really tell us a lot, and they're really words that are much easier to be confusing. So as nurses, it's important for us to be aware of some of the older terminology and the newer terminology and classifications, and to use clear communications, transparent language, to say what we mean. When we're talking with colleagues, use the clear medical definitions and words. When we're talking with people with epilepsy and their families, understand what words they use. What do they mean if they use the vaguer terminology? Correct the discrepancies, the myths or misbeliefs they have about seizures, epilepsy, or the type of seizures that they have. And work or strive for that shared understanding. Because if you all have that same understanding about what seizures and epilepsy are, you'll be on that same journey forward. and which is really to help people with epilepsy get the accurate diagnosis and treatment and the best quality of life that they can.
Hello, my name is Melissa. I'm from Westmead Hospital in Sydney, Australia. Thank you for the opportunity of speaking today. I'm going to be talking about the labels in epilepsy, meaning and importance in focal epilepsy. I have a disclaimer. The permission and consent has been obtained for the person with epilepsy and their family to present videos and history for the educational purpose of nurses in this ILAE webinar. I will be using a case presentation to focus the discussion on words and terms used to describe mesial temporal lobe epilepsy with hippocampal sclerosis. As the diagram demonstrates, mesial temporal lobe epilepsy with HS is one of the ILAE-defined syndromes with onset at a variable age. Mesial temporal lobe epilepsy with hippocampal sclerosis is a focal epilepsy syndrome. The diagnostic criteria include seizure types of focal aware or focal impaired awareness, with semiology that is consistent with temporal lobe epilepsy, and MRI imaging demonstrating hippocampal sclerosis. Ictal EEG is not required for diagnosis, and the population prevalence of mesial temporal lobe epilepsy with hippocampal sclerosis is not well studied, but there is one study from the United States that estimated drug-resistant mesial temporal lobe epilepsy with hippocampal sclerosis to be between 143,000 and 191,000 people. But this data was largely collected from an epilepsy surgery centres, and there's thought that there might be some bias in the collection process. As I go through the case history, I've emphasised in bold lettering and in the comments in red that will highlight key information which contributes to the diagnosis and can impact on care. So our person with epilepsy is a 53-year-old right-handed female with seizure onset at the age of 18. She has two seizure types, the first being a blank with bilateral leg shaking, and the second being a feeling of hot flushing that then progresses to being blank. Duration of the seizure type 1 is 5 to 15 minutes, and seizure type 2, 30 to 60 seconds. Frequency is twice per week, according to her husband, and she would report seizures twice per month. Triggers include tiredness and alcohol. Longest seizure-free period is 4 months. Current medications include levetiracetam, zonisamide and lamotrigine, with previous trials of phenytoin, valproate and phenobarbital. Risk factors or antecedents include a febrile convulsion. From the case history, there are a few things I'd like to highlight just from a learning perspective. Based on handedness, there can be an assumption can be made that she's left hemisphere dominant. Age of onset of 18 years of age is consistent with mesial temporal lobe epilepsy with HS, with typical onset in adolescence and young adulthood, but can occur at any age. The duration of epilepsy is around 35 years, and this can be associated with reduced seizure outcomes for epilepsy surgery, but is not contraindicated. Trialing greater than 2 appropriate anti-seizure medication means our person with epilepsy has drug-resistant epilepsy, and the febrile convulsion that she suffered has been associated with hippocampal sclerosis in the literature. Our person with epilepsy is culturally and linguistically diverse. She speaks Central Thai and English. She lives with her husband in northern coastal New South Wales. She has 1 son and grandchildren living in Thailand. She's currently not working due to seizures, but previously worked in cleaning and agriculture in Thailand. She's unable to drive. On assessment, she has mild depression and anxiety. Anti-seizure medications are making her slow and drowsy, and her neuropsychological assessment identified impaired verbal learning and memory. The neuroimaging demonstrates small left hippocampus, as indicated by the red circles. The image on the right shows less defined swirls in the left hippocampus, indicating a loss of structure when compared to the right. The image on the left shows the hippocampus is brighter, indicating increased signal. Smaller hippocampus with loss of internal structure and increased signal demonstrates the features of hippocampal sclerosis. Focusing on describing or reporting seizures of mesial temporal lobe epilepsy with hippocampal sclerosis is an essential skill for nurses involved in the care of people with epilepsy. Focal aware seizures can go unrecognised or be mislabelled, as they are typically subjective and vary because the person with epilepsy has their own description. The semiology of focal aware seizures in mesial temporal lobe epilepsy with hippocampal sclerosis is divided into autonomic, with examples such as rising epigastric sensation, abdominal discomfort, nausea, flushing and tachycardia. And some of these features can be also associated with cardiac and anxiety disorders and can lead to delays in diagnosis and even misdiagnosis. There's cognitive, with an example of déjà vu or a sense of familiarity. Emotional, such as fear or euphoria that's not consistent with a situation. Sensory, including olfactory or gustatory, so a sense of smell or taste. And then the semiology of focal impaired seizures are behavioural arrest with automatisms, oral, manual and gestural, and speech may be present in the non-dominant temporal lobe focus. I'm now going to show you a video of our person with epilepsy.
But after finding the nearest point of complete relief, a lot of people in this situation drop their ball pretty close to this point and hit the drug. So do yourself a favor and use the rules to your benefit. When the ball lies in the general area, you must drop it into the general area. If you prevent one ball line from the nearest point of complete relief, then the airway would be included in the relief area. So there may be a difference as players.
When describing seizures, the terms used are important to understand the meaning of the terms and to avoid misdiagnosis and to ensure the best care of the person with epilepsy. By reviewing our witness description and the video of the seizure, I'm going to compare some of the words used to describe focal seizures. So seizure type 1, focal impaired awareness, so non-motor behavioural arrest indicated by the word blank, to bilateral tonic-clonic, which bilateral leg shaking. This is a maybe based on the duration of the reported seizure by the observer. So previous terminology, complex partial seizure, focal dyscognitive seizure to bilateral tonic-clonic. Seizure type 2, focal aware, so non-motor with autonomic, the hot flushing, to focal impaired awareness with behavioural arrest, the blank. Previous terminology could be simple partial seizure, aura, to complex partial seizure, or focal dyscognitive. And when we reviewed the seizure on the video, you could assume that there may have been a focal aware seizure at the beginning, but wasn't indicated, that then progressed on to a behavioural arrest, developing into motor, oral and manual automatisms. And that could be described in previous terminology as complex partial seizures or focal dyscognitive. It is important to ensure the goals of treatment are identified. For our person with epilepsy, her goals were to return to working and improve isolation by learning to drive. Treatment options are continuing trial of anti-seizure medications, aiming for seizure freedom, although chances of seizure freedom are around 20% with continued trials of anti-seizure medications, but also improving side effect profiles, ensuring the balance of side effects with seizure frequency is essential. Clinical trials of new and emerging medications is an option, but frequency of visits and distance would make this difficult. The surgical treatment of mesial temporal lobe epilepsy with hippocampal sclerosis in our centre would include an anatomical left temporal lobectomy. Other international centres complete procedures including laser interstitial thermal therapy and selective amygdala hippocampectomy. Factors to consider with surgery include procedural risk, including stroke, hemorrhage, infection, and further decline in verbal language and memory. Secondary factors include how age would impact on risks and recovery. Seizure outcomes for epilepsy surgery for mesial temporal lobe epilepsy can range from 53 to 84% seizure freedom. Key predictors of people with mesial temporal lobe epilepsy with hippocampal sclerosis include duration of epilepsy and the presence of tonic-clonic seizures. Education on the long-term continuation of anti-seizure medication is also a predictor of long-term seizure outcomes, ensuring the discussion with the person that epilepsy surgery doesn't mean a cure and that anti-seizure medications should be continued long-term. How do the seizures in any form impact on daily activities? For our person with epilepsy, the burden identified from our history includes frequent small seizures. The word small has an association with a meaning of benign and low impact, but this term can be misleading and indicate the seizures are not a burden. Medication, so side effects, the costs, and the difficulties of remembering to take them. Social isolation, having emigrated from Thailand, she's unable to drive, impacting independence, not able to work, and a social embarrassment from the seizures will often attempt to hide the seizures that they occur in public. Elevated symptoms of depression and anxiety, struggles with her memory, and difficulties completing citizenship requirements due to learning and memory impairment. The role of the nurse is multifaceted in the care of the person with mesial temporal lobe epilepsy and hippocampal sclerosis. It is holistic and individualized for each person and their family. For our person with epilepsy, the care included education around the different treatment options and ensuring they were able to make informed decisions. Supportive care strategies to improve taking anti-seizure medications independently, assisting and engaging epilepsy advocacy groups for community education about different seizure types to improve social awareness and stigma, advocacy by providing documentation for citizenship applications, access to local support services by enabling connections with local services. The nursing role is an essential aspect of care for all people with epilepsy, but is tailored to meet the care needs over the lifespan. Here are my references, and thank you for allowing me this opportunity to talk today.
Hello, everyone. Thank you for the introduction, and thank you for the opportunity to speak today on labels in generalized epilepsies, and specifically on juvenile myoclonic epilepsy. I have no disclosures that are relevant to today's presentation. I'd like to introduce you to Michael. And Michael is a 19-year-old young man who I met in my first seizure clinic. And he presented to my first seizure clinic after having a witnessed tonic-clonic seizure in the parking lot of a fast food restaurant with his friends. And I use the term tonic-clonic seizure rather than generalized tonic-clonic seizure or focal to bilateral tonic-clonic seizure at this point, because at this point all I know is that it was a convulsive seizure. I don't know if it started as a generalized onset or if it was focal and progressed. So at this point, it is a tonic-clonic seizure of unknown onset. Michael's friends also reported that he had had some twitching and some jerking of his limbs and was walking kind of funny before it happened. So now we need to find out more about this story, about what happened to Michael, about his history, and asking the right questions is key. Some of the questions that I've asked when I see patients like Michael or asked Michael and his mother when they were in my clinic were things like, have you ever had a seizure before? Do you ever have any funny spells of any kind? Do you frequently drop things or throw things, toothbrushes, coffee cups? Do family and friends tell you you're clumsy? Do people ever tell you that you stare off and don't respond to them, like you're not there? Do you ever notice that you miss parts of conversations or shows that you're watching? Do you have any movements of your body that you can't control? Do you ever have any jerking of your limbs that you can't control? Have you ever woken up with an unexplained injury or a bitten tongue or blood on your pillow? So when these questions were asked of Michael and his mother, what I found out was that he had about a 2-year history of brief twitching of his arms, especially in the early morning, or if he was up late and overtired. His family and friends do call him clumsy because he often drops or throws items. And Michael reported that one night a few weeks ago, he was out late with his friends. He had been drinking some alcohol, and he woke up the next morning. His body was sore all over, and he had didn't feel well, and he had a laceration on the side of his tongue from a tongue bite. He didn't know what had happened, and he didn't report it to anyone. So that was Michael's story. The remainder of this talk will focus on the generalized seizure types, the generalized epilepsies, and the generalized epilepsy syndromes, and specifically juvenile myoclonic epilepsy. Genetic generalized epilepsies are a broad group of epilepsies with generalized seizure types, generalized spike and wave on EEG, and a presumed genetic etiology. Idiopathic generalized epilepsies pertains to a distinct subgroup of the genetic generalized epilepsy, and these make up approximately 15 to 20% of persons with epilepsy. The idiopathic generalized epilepsies are the most common syndromes within the genetic generalized epilepsies. They generally have a very good prognosis for seizure control. They do not evolve to epileptic encephalopathies. There are 4 syndromes in the idiopathic generalized epilepsies. These are childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone. There is some clinical overlap, as you can see from the cartoon, between the childhood absence epilepsy, juvenile absence epilepsy, and juvenile myoclonic epilepsy, and these can evolve with time from one idiopathic generalized epilepsy syndrome to another. The idiopathic generalized epilepsies have a polygenic influence with or without environmental factors. JME, or juvenile myoclonic epilepsy, is the most common adolescent and adult onset idiopathic generalized epilepsy. It has a prevalence between 1 and 3 per 10,000 persons, and it accounts for almost 10% of all epilepsies. It's characterized by myoclonic jerks and generalized tonic-clonic seizures in an otherwise normal adolescent or adult. Age of onset is usually between ages 10 and 24. They identify the range as between 8 and 40, but certainly we have diagnosed individuals outside of both ends of that range. There is a slight female preponderance. The predominant seizure type is myoclonic jerks, and they typically occur early in the morning after awakening or when overly tired. Other seizure types are present in juvenile myoclonic epilepsy. Specifically, generalized tonic-clonic seizures occur in more than 90% of individuals with JME. Absence seizures are present in about a third of individuals with JME. And there's a history of febrile seizures in 4 to 5%. Juvenile myoclonic epilepsy individuals have normal development, and it's not usually associated with any intellectual disability. However, mood disorders, ADHD, and learning disabilities are common comorbidities, as they are in many epilepsies. A common seizure trigger is sleep deprivation, and alcohol use and photic stimulation have also been known to trigger seizures. JME is usually considered a lifelong disorder, and it usually requires lifelong treatment. Most individuals with JME are responsive to anti-seizure medications as long as the proper anti-seizure medication is selected. Myoclonic seizures sometimes are a little more difficult to control than generalized tonic-clonic seizures in some individuals. And some of our sodium channel blockers, carbamazepine, oxcarbazepine, and phenytoin, can aggravate myoclonic seizures and absence seizures in JME. And lamotrigine has been known to aggravate myoclonic seizures in some individuals. In others, it can be used without any difficulty. The treatment of choice for juvenile myoclonic epilepsy is valproic acid. That is with the exception of women of childbearing potential, because of the known teratogenic effects of valproic acid. Investigations in JME. I just briefly want to touch on this. A routine interictal EEG will show a normal background and will show the generalized spike in wave and polyspike in wave in all states. There is usually a photoparoxysmal response in between 30 and 90% of individuals. So with photic stimulation during EEG, you will see a photoparoxysmal response and may see myoclonic jerks or a generalized tonic-clonic seizure. So this should be used with caution. And hyperventilation will induce generalized spike and wave discharges in about a third of individuals with JME on their EEG, but it rarely produces a clinical seizure. Neuroimaging is normal, so there is no structural brain abnormality associated with this disorder. And if your clinical presentation and your routine EEG are typical for JME, no further imaging is required. Most individuals will have had a screening CT scan when they presented to their local emergency department with their first convulsive event to rule out any other underlying cause, but there is no need for an MRI, and an ictal EEG is not required to diagnose this disorder. In regards to genetics and JME, genetic testing is not part of the current routine diagnostic workup for JME. Clinical studies and twin studies have shown that JME does have a strong genetic component, and a family history of epilepsy associated with generalized seizures is supportive of the diagnosis and is occasionally present, but it's most common for patients having any one of the idiopathic generalized epilepsies not to have a family history of epilepsy. And typically, if there is an affected family member, they will have one of the idiopathic generalized epilepsies, but not necessarily JME. Some of the terminology that I used earlier in the presentation I want to discuss, genetic versus hereditary. So genetic diseases are pathologies that occur because of an alteration in our genetic material, in our DNA, and the mutations can be caused by an error in DNA replication, or it can be caused by an environmental factor that affects our DNA. Hereditary is when a disease is passed on, when the alteration in genetic material is passed from a parent to a child. So we can have genetic abnormalities simply from a glitch in our own genes, or we can have genetic abnormalities that are hereditary and passed on to us from our parents. Polygenic influence means that the trait is produced from the cumulative effects of alterations in multiple genes rather than a single specific genetic mutation. And idiopathic generalized epilepsies have a polygenic influence, and that may be associated to environmental factors or not. But what this means is it takes multiple alterations in multiple genes to have a diagnosis or the effect, which is usually the juvenile myoclonic epilepsies or one of the other idiopathic generalized epilepsies. And that's why genetic testing is not usually done, because it's impossible to know where to look when it's from multiple genes that are different in each person with JME. Seizure terminology, the seizure types that I spoke about were absence seizures, and that is a very brief onset seizure. It's usually less than 10 seconds. There is a cessation of activity, a blank stare. They're unresponsive to those around them. Their eyes may seem to drift up or roll back, and they may blink or have fluttering of their eyelids. They're out of contact and have loss of awareness during that brief period of time. They rapidly return to normal. They're usually unaware that they've had a seizure, but they may sense that they missed something. And the old and inappropriate term for an absence seizure is a petit mal or petite mal seizure, and that term should not be used anymore. We should be using the correct terminology of absence seizure. I want to show this little video of this young fella. You will see he's sitting at the table doing his homework, and his dad is helping him. And you will see that he suddenly stops in activity. He's staring. He's out of contact. He had some little bit of blinking, and he's quickly back to normal. He actually says, huh, to his dad there because his dad was speaking to him and he didn't respond. And you'll see he has one more. His brother is talking at this point, and there he is. He's staring. He's out of contact. He's stopped in his activity, and he's back. and he's going to start his activities again. The other seizure terminology I used was myoclonic jerk. And a myoclonic jerk is a generalized onset seizure. It causes a brief jerking spasm of a muscle or muscle group. It usually involves the neck and shoulders and the upper arms, but it can involve other body parts. Patients or individuals with myoclonic jerks will often refer to them as shock-like, and they usually remain aware and alert during those seizures. And I'll show a little video of that. Oh yeah, and the other seizure type I talked about was generalized tonic-clonic seizures, and the old inappropriate term is grand mal seizure and should not be used. And here's a little video of myoclonic jerks. You'll see that individual just had one, and there's another one. You see the shoulders come forward and up. There's a couple more on this video. There's another one, and they turn to the front, and you can see it happening front on in this last example. There it is there. Shoulders come in and forward. So nursing considerations in juvenile myoclonic epilepsy. Asking the right questions and exploring the responses is key. We have to know what the story is and what has happened to this individual over time to understand what is accurately happening to them. We have to understand and teach the proper terminology. So having my twitching spell should be corrected to a myoclonic seizure or myoclonic jerk. And my zone out spells should be corrected to an absence seizure. They need to know these are seizures. They need to use the correct terms when they're telling other people about their medical conditions. We need to assess for comorbidities when we see individuals with juvenile myoclonic epilepsy. We have to assess for mood disorders, whether there's anxiety or depression, learning disorders, ADHD, and then we need to link them with resources. Safety considerations are key in individuals with juvenile myoclonic epilepsy. These are young adults usually. They are transitioning from being controlled by their parents in a controlled environment to teenagers and young adults who are experimenting with alcohol and sometimes with social drugs. And that matters, and late nights matter. And so safety considerations and counseling around medication use, about the importance of taking medication even if you're going to be out having some alcohol to protect you further from any possible seizures, side effects, medications that may worsen seizures, all important part of the counseling. Family planning counseling is key in anyone, but in young women with juvenile myoclonic epilepsy, it is so important. And in particular, paying attention to no valproic acid for young women with childbearing potential, or if it is needed as their only way of controlling their seizures, then counseling around avoiding pregnancy is key. Seizure triggers, again, sleep deprivation, photic stimulation, alcohol overuse, that counseling needs to be done. And of course, the safety around driving. This is when young people get their driver's license, and we need to make sure they're safe. Quickly back to Michael. Michael was identified as having myoclonic jerks, generalized tonic-clonic seizures. His CT scan of his head in the emergency department when he presented that day was normal. His EEG was typical for JME, and he was diagnosed with JME and treated with valproic acid, and he's doing very well. He was screened for comorbidities. His driving license was medically suspended for 6 months, and he was counseled on medications, seizure triggers, and lifestyle factors. Thank you very much. Appreciate your time, and I'm here to answer questions.
Well, Thank you again to our speakers. We have a few minutes for questions or points of discussion, if you would like to put them in the chat. But just to kick us off, I would just say that, it is not an easy thing to describe seizures. And one of the challenges in working with patients is that we rely on witnessed accounts. We also rely on what patients say. Unfortunately, when patients lose awareness, it's not easy, it's almost impossible for them to describe their seizures. So I'm just wondering, from our speakers, what suggestions do you have to help clinicians to elicit correct descriptions of seizures? After all, this is the first point of departure when it comes to making a correct diagnosis. So, Karen, perhaps you can kick us off and just what tips do you have for people in clinic when they arrive with a new onset seizure and you're really not sure what's happened?
Yeah, it really is about digging and asking. And then when you get the answer, asking more. We also highly encourage families and individuals, if they have a video recording this day and age with everyone with a phone in their pocket, and the tendency in particular in young people to videotape everything. Sometimes we're lucky enough that they have captured the spell, and we certainly ask for that if it's come. But it really is about asking more every time you think. Sometimes we get people to demonstrate. Can you show me what that looked like? Whatever you can do to get a better understanding of exactly what it looked like or what it felt like to the individual or to the witness.
Sandy, I want to comment here because I think this showed focal epilepsy that starts with steering, and then the absence seizures. And I think what was so interesting here, as I listened to it, I said the approach that and the answers that Karen got in the first seizure clinic kind of took her and the patient and family down one pathway, right? And so there's a certain journey that they take. Yet, if Karen hadn't been there and they hadn't gotten that, and then the person presents, let's say years down the road, into an epilepsy monitoring unit, you might be looking at it totally different. The person might have been taught different words to use or not had the correct language, and it might take you down the wrong path. So I think just hearing the way that Melissa did the questioning and how she clarified the descriptions that, that person had versus that Karen did clearly showed you the pathway that the patient goes down, which I think really highlights the role of the nurse well.
Right. I'd like to comment more on that, Patty, but I think there were a couple of questions in the chat. The first question came in from, during myoclonic jerks, is the patient aware? You might want to take that one, Karen.
Yeah. Most times patients are aware when they've had myoclonic jerks. And if you, the videos that you saw today were off of, on my presentation, were off of YouTube. And there are actually some interesting ones on there where the patients themselves have videotaped themselves and are saying, I'm taping today because I'm having so many myoclonic jerks, and I wanted to be able to show you what they looked like. And it indeed shows individuals having myoclonic jerks. So yes, in most cases, individuals who experience myoclonic jerks are aware during those seizures.
So can I jump in there? So a myoclonic jerk could actually have focal onset, or a generalized onset. And so that's where the further clarification and terminology is. And if you look at the position statement, the classifications of the epilepsies and seizure types of ILAE, for the generalized seizures, and they even comment about this for the myoclonic and some of the brief ones, that essentially you're assuming that awareness is affected to some degree, but you can't really tell, and it may look like it's not impaired by myoclonic or not. And so there's really no way to definitively say
in that one where they were or not, unless the person was talking throughout it. But that's a good question.
It's a good question. And I think it's often very difficult to know whether someone's awareness is impacted, because people can't report loss of awareness when they're not aware. The other thing that's interesting too is, in absence seizures, we can have clustered absence seizures in which people are seemingly aware. They can eat a meal during, rapid eye blinking that can go on for many minutes and sometimes hours of the day. There are probably periods of time when their awareness is altered. It's often difficult to say. There is another question here. So Andy writes, when a question doesn't relate directly, he's concerned his question doesn't relate directly to content, but he says, when I hear patients or loved ones call themselves epileptic, I endeavor to subtly deter them from defining themselves as epileptic. How would the team view this word, use of the word epileptic?
I totally agree. And in a previous lifetime, before I started doing neurology, I did diabetes, and we did the same thing. We would say, you are not diabetic, you have diabetes. You are not epileptic, you are 1,000 things. Oh, and by the way, you have epilepsy. But I agree with you. I don't like to see one part of your life define exactly who you are. And I am of the same mindset.
Right.
Same here.
There's one other question here. Typical age of onset for absence epilepsy. Somewhere within the first decade, early in the first decade of life. Another question here about the patient with temporal lobe epilepsy. Are the 15-minute seizures possibly psychogenic? So I'll defer that to Melissa.
I think that's a really good question. I think we come back to where Karen was talking about, where we're talking about history, is that sometimes the duration of the seizure is misinterpreted, or just it feels longer for the witness with seizures. And I think that's an important part of our history taking, is that what we might see is that the duration of the seizure could include both the seizure itself, but also the post-seizure or the post-ictal phase, which will include recovery back to their normal self. And I think sometimes witnesses will take that into their observations of the seizures. And it's important for us to try and kind of deconstruct that as epilepsy nurses, to ask them specific questions. And specifically in the video I showed, as soon as the person with epilepsy is lying back down, the seizure is actually done in that kind of instance. The other thing to take into consideration is it a tonic-clonic seizure, and has that impacted the length of the duration of the seizure and recovery as well? But yes, definitely in the world, we think 15-minute seizures. We do often think non-epileptic seizures as a consideration in our history-taking process, and I think that's important.
So Melissa, let me just ask you a question on that. And if you said this, I'm sorry, I was looking at something too. But I mean, so what the person reports may include a lot of other variables that aren't seizures, or they're not aware. That's one thing. But then don't you find that many times even what you as a nurse might see, so clinically what is seen, doesn't equate with actually the epileptiform changes on EEG? So do you see that? And so then you need to define, there's different ways to define seizure, your EEG change versus what you see. Is that correct?
Yeah, so clinical as well as EEG. And I think often the EEG part is difficult to define, especially if you're not in a monitoring unit. And this is where, as an epilepsy nurse, we get this phone call and they say, oh, well, the seizure's been going on for 20 or 30 minutes. And in that situation, it is quite difficult to figure out, is it actually ongoing changes in the EEG that's causing them to be a little bit more confused or slow after the seizure? Or is it just that they are post-ictal? And I think that the EEG can be a complicating factor in just discussing kind of duration of seizures, because sometimes the interpretation can be confusing. And I think that I often try to kind of say to the people, are they back to their normal selves? You know, is this what they were like before the seizure started, or do you think they're still a little bit not themselves, to try and kind of establish the difference between what the person with epilepsy and their observer or witness is describing. And then even then, sometimes it's difficult to establish.
Yeah. In a first seizure clinic, everybody comes in saying, because they've witnessed this first event, it terrified them, and they are certain it was 10 to 15 minutes long every time. And then we actually make them walk through it and we time it. So we say, okay, you walked into the room and what happened? And then we're watching the clock. And now tell me what happened next, and tell me what happened next. And we say, you realize that only 25 seconds have passed. And so they're like, oh, it seems so much longer. And we're like, yeah.
And that I think that covers nurses as well. You know, in the adrenaline kind of situation, anyone witnessing seizures, this same kind of phenomenon can occur, is that we feel like it's been forever, but in actual fact, it's just been a couple of minutes.
Yeah.
You know, there are lots of lovely questions here in the chat, which we are not going to have time to get to. So I think if anybody wants to reach out to the speakers or to any one of us, we can certainly answer these questions.
Sandy, you want me to run through some of them?
I'd like to ask Rachel this one, because it's the same one Karen and I talked to her about. So,
Yes.
I mean, excuse me, to ask Melissa. This is from Rachel. She's from the UK. Why was your second patient not offered surgery before the age of 50, as that seems quite late? So this kind of goes back to her social history and where she came from.
Right.
So I think
It does. And this is the lady herself didn't migrate to Australia into her late 40s. And I think the opportunity and the investigation, she was living in kind of a rural village in Thailand. And as you can kind of notice from her previous seizure medications, you'd actually tried some of the older seizure medications such as phenobarb and phenytoin. And I think that the opportunity for epilepsy surgery wasn't actually available to her. And when she did migrate to Australia, she's migrated to a kind of rural, regional, coastal town, and she has to travel 500 kilometers to see her epilepsy specialist. So there are kind of closer neurologists, say 100 or 200 kilometers, but the epilepsy specialist is quite far away. And I think that appropriate referral and identification of the refractory nature of her epilepsy has impacted why she's not been offered surgery closer or in a younger kind of age group. And we did talk about this a little bit, is that the thought that mesial temporal lobe epilepsy is a dying kind of diagnostic syndrome. But we are seeing people that are younger now that have more available options in addressing kind of epilepsy surgery than they did 10, 15 years ago. And I think being aware and early referral is something that is difficult to account for in any kind of country or rural, regional areas across the world.
And I see that Catherine has said we can go beyond our 5 o'clock, or 5 o'clock in Halifax,
Yes.
Nova Scotia, Canada cutoff. So maybe we can attack some of those other questions. I see Lorraine.
Well, I was just going to say, Karen, we should try to sort of keep with our the theme about our talks today, you know, with the labels and
I mean, I don't mind touching on Lorraine had asked if there was overabundance, reliance on medication, child stuff, and transition. And I think, no, I don't think there's an overabundance reliance on medication. The most important thing we can do is get individuals seizure free. The longer they're not seizure free, the more poor outcomes we know happen. So I think the medication should be used when they're needed and get those seizures stopped. If you can sign up online or come to Dublin, you might have the chance to hear a wonderful talk at the International Epilepsy Congress. We're having a talk on nurse-run transition clinic or nurse-led transition clinic, going from nurse to nurse in pediatric to adults, which will be a great opportunity to improve transition care. And the third question was around play therapy. And certainly, whatever works. And I am an adult care provider, so I don't know what's out there for pediatric play therapy to teach kids the right terms. But totally agree.
So just to piggyback on that, Karen, I think one of the important things about the medicines is that we need to be sure before we start medicines that this is indeed epilepsy. And just to draw your attention to some of the literature that's shown that as many as 1/3 of adults and more than that of children are incorrectly started on epilepsy medicines. And they eventually referred to an epileptologist if they're lucky, only to discover that actually they don't have epilepsy at all. Many of the adults, I think 1/3 of those were psychogenic, but of course, you know, the other 2/3 were not epilepsy at all. But you know, to carry an incorrect diagnosis of epilepsy also has severe negative consequences, you know, psychosocially, psychologically, socially, all these things. So, you know, it goes sort of both ways. At the same time, not recognizing epilepsy leaves people in the situation perhaps of the temporal lobe patient earlier that can go for quite a long time, but sometimes 9 or 10 years before the epilepsy is actually diagnosed. So I think, you know, being sure of diagnosis really rests very much on the words we use, and we need to listen to patients and the words that they use. And certainly some of the language will help us to differentiate psychogenic seizures from epileptic seizures. People use certain language. I think there's a lot of research opportunity there to look at the language people use and how helpful it is diagnostically. And I would just add one more point about seizure diaries, is that often we rely on seizure diaries, and particularly for people that are in research studies. And there's nothing wrong with using people's own words to differentiate seizure types. I would just put that out there, except that people should know, you know, which broad category their seizures are, and that they actually indeed are seizures, and that focal aware seizures are seizures. Auras are not absences, and they are not seizures. So I would just put that out as a reminder. Is there anything else in the chat that you think we should pick up?
The question from Vancouver, Canada, where the distinguishing between focal impaired aware seizure and an absence seizure, and it really is about all that kind of questioning. So you know, the length of time of the event, a focal seizure, again, you saw that little fella in the video, how very brief it was. They tend to be less than 10 seconds or so in duration, and they rapidly return to normal, and they just carry on. So if you have something that has lasted 45 seconds, where someone was blank, out of contact, had some automatisms where they might be lip smacking or fumbling about with Kleenex boxes or who knows what, and it lasted longer, then your hint would be the other way. The other thing is age of onset, although I was laughing because the patient Melissa presented, in my case, were both onset around 18 years old. But you know, if you have somebody coming in at an older age who older than that, you know, 10 to 25 age, with their onset, that's another. So it's all little tiny clues about what happens, what they're like before it, what they're like after it. Did they have any warning? Did they have a rising epigastric phenomenon beforehand? Those are all little clues that take you down one path or the other.
Well said.
Nice answer, Karen. Yeah.
And
Well,
I did not hear anything about valproic acid in males under 55, Jackie. Maybe do you know why in the UK that was recommended? I'll wait and see if you type something, Jackie.
yeah. I have not come across that either.
Yeah, I don't, that's certainly not in North America, I don't think at all. I don't know about Melissa, any restrictions on
in Australia, it's just kind of childbearing age women.
Yeah.
It really is defined by that childbearing age kind of age range.
Yeah. Thank
So
you
just
for
to
sharing,
say,
Janet.
yeah.
This
Just to
is
say,
the
you know,
NICE
that
guidelines, I think.
our classifications have changed as the field has advanced. So with the 2017 classification was really largely influenced by our improved imaging. And, there are hallmarks at each point at which the classifications have changed. There's usually, some scientific advancement. And of course, we now in the whole world of genetics, which has helped us even more. And identifying syndromes is like the third and most sort of sophisticated element of classification. But I think as nurses, we can very easily use that first level of classification and play an extremely important role in helping patients to describe what they're having, or have caregivers to describe the features of seizures. So I think, is there any last minute thing anybody would like to say, or shall we
No, I just wanted to let Kamara Anthony know that we do see that question, but that's a whole nother talk on its own, the discussion of progressive myoclonic epilepsies. So we'll save that one perhaps for another day. And I'm going to look into that valproic acid restriction in the UK. We certainly don't have it here in North America.
Mm-hmm. Right. So thank you for all these wonderful comments in the discussion. I'm really thrilled that we had time for some extra discussion. The talks were very inspiring, and we welcome comments and email communications from anybody. In summary, I had a quick slide in summary. Hopefully this will be relevant here. We'll just say that our speakers have, highlighted the importance of using correct language. And just as a take-home message would say, that a common language is necessary for clinical communication, and very specifically in a research area. It's very important that descriptive words used by clinicians and patients are correctly elicited, because this impacts the diagnostic process. It impacts the treatment selection, and it also impacts the timeliness of interventions. And we saw this very specifically, especially in that temporal lobe case. I would also just bring us back to an age-old problem that words do matter when it comes to overcoming stigma. So we appreciate the question about the use of the word epileptic, which a lot of people do not like. And, just to finally say, that, there's still much work to do on this. It's a very contentious subject. Finding the right language has been difficult. It's been debated over many years and extensively by task forces of the ILAE. So it's certainly an evolving topic, I think. And with that, we hope that you've enjoyed the presentations, and we thank you for your attention. And please stay tuned for our next webinar. Thank you, everybody.
Thanks, everyone.
Thank you.